Hello class. What I wanted to do was briefly do a quick video about the SP encounter we had on Thursday. It's essentially a post-SP encounter wrap-up. As you all have witnessed by now, the exam was on a 50-year-old female presenting with right-sided chest pain and tenderness, and essentially the chest pain was around the outer portion of her right breast. Clinical reasoning in this particular case warranted a breast exam. The fact that the patient had never had a mammogram prior at the age of 50 and had done some scant breast exams in the past, and now she's presenting to your office with some breast pain and also noticed a lump in the breast tissue as well. As chiropractors in the state of California and in Oregon, we can perform self-breast exams, and in my experience, anecdotally, patients have walked into my office and say, "Doc, I have this altered sensation around the breast or this odd feeling when I palpate. Could you assess it for me?" And again, with having my female staff in the office, I would briefly look at it as well. So what I gave you guys was not out of the picture, it was not out of the ordinary. As doctors, this exam was highly appropriate. The fact that I'm looking at vertical integration of our curriculum, the fact that you were taught these procedures in Tri 5, and not only that, I like to call it foreshadowing. I gave you the checklist in the class. We briefly discussed it in the class as well. So I thought it was warranted and highly applicable and appropriate for your SP encounter. So with that being said, a couple of things with the SP encounter. Ultimately, the diagnosis I was looking for this particular case essentially was non-cyclic mastalgia. And the reason for the non-cyclic mastalgia would be that most breast pain can be categorized into three underlying categories: cyclic mastalgia, non-cyclic mastalgia, or non-mammary pain. Cyclic mastalgia, by definition, is usually diffuse, bilateral, often radiating to the axilla and arm, and related to the woman's menstrual cycle. Pain occurs during the luteal phase and resolves with the onset of menses. And in some cases, it can be unilateral. However, in our particular scenario, non-cyclic mastalgia, even if you had diagnosed the patient with mastalgia, I would have given you full points. By definition, it may be continuous or intermittent, but it is not associated with the menstrual cycle. It is more commonly unilateral and more prevalent in premenopausal women. By definition, non-mammary pain is breast pain secondary to an underlying or another etiology. This is often chest wall pain, but sometimes the underlying cause may be difficult to determine. Now, when we look at the etiology of most mastalgia, it's unknown, but there's some common causes for mastalgia, and some of them could be pregnancy, thrombophlebitis, a cyst, musculoskeletal cause, and individuals that are taking medications like over-the-counter, oral contraceptive pills, antidepressants, antipsychotics, antihypertensive meds are some common medications that can be underlying causes of mastalgia. So for this particular case, the underlying diagnosis I was looking for was non-cyclic mastalgia. If you picked that, you got full points. I gave you partial points if you picked cyst. And then even if you picked cancer, I gave you some points for that as well. But again, as I will show you with Dr. LeDuc's PowerPoints that she has shared with me, that breast cancer is least likely in this case. Again, hopefully, let me go to that PowerPoint here on breast cancer. And in this PowerPoint that Dr. LeDuc has shared with me on breast cancer, I will go to slide 7, and slide 7 indicates that classic signs and symptoms of breast cancer. Orange peel appearance on the skin, visible bump, nipple retraction sign, painless palpation in the early stages, increased venous pattern unilaterally, and breast edema. Now, our patient presented with none of these. Again, here is the depiction of the orange-looking sensation, erythema, edema, all classical signs of breast cancer. I will go to slide 11 to validate again why this patient did not have breast cancer. And I will point out that early stages of breast cancer are non-tender. Lump, firm, fixed, and well-defined is typically noted. Now, in our particular scenario, the patient had a 2 centimeter firm, well-circumscribed, movable mass that is tender, moderately tender. So again, lymph nodes, again, were not swollen in any means in our particular scenario. The sheet that you had indicated that no axillary, supraclavicular, or cervical lymphadenopathy is appreciated or noted. So again, that is why breast cancer is the least likely diagnosis in this case. However, if you still are suspecting it, again, there was no family history of this. So I agreed with some of you to say, sure, let's refer them out for a mammogram. And ultimately, in this case, I would have wanted you to clinically manage the patient by sending them out for a mammogram, but not only sending them out for a mammogram and sending them out to their OBGYN or to their primary care for that mammogram or thermography, I think was highly warranted in this case, but very important, which a lot of you did not stress, was this one right here, that the patient must perform self-breast exams, and you need to maybe inform the patient on how to perform them, or at least educate them on the frequency of performing the self-breast exams as well. So ultimately, for the management for this particular case, I was looking for referral or co-management. I was looking for referral to the OBGYN or the primary care for mammogram or thermography, recommending to the patient self-breast exams or annual exams, also nutritional management, anti-inflammatory foods that will have phytoestrogens, foods that are good, or nutritional sources that are excellent for cancer prevention, like soy, beans, legumes, lycopenes, tocopherols, vitamin A, selenium. We talked about a lot of these in class when we were referencing even the prostate cancer. So again, when we look at preventative measure, those are some sources that you could have recommended to the patient as well. And then ultimately educating the patient on the warning signs of cancer. So again, just educating her about what are some things to look for. Now, when I reviewed some of the videos, some of the underlying themes or consistencies that I noticed was students did not undrape the patient for the actual exam. They did not vocalize what they were doing on the exam, and definitely displayed a lack of confidence with the exam as well. Students were telling me that they were visualizing things, but the patient was fully gowned. So I'm not sure how you could visualize something if the patient was fully gowned, and or you were palpating under the gown as well. So that's pretty much where we are with this clinical scenario. And I guess if you would like to make an appointment with me, by all means do so. What I will be doing is releasing the videos to you to do a self-reflection. Now, I'm going to stress, if you want to review your exam with me, you need to watch your video, identify that physical exam process that you engaged in, from visualization to asymmetry, looking at the various visual clinical clues, palpating in a circular motion, and then finally pinching the nipple at the end, looking for any discharge. So again, as you are reviewing your videos and you're doing a self-reflection, if you are going to come in and discuss this with me, from your history-taking skills on specific questions to the actual breast exam procedure, I want you to document that on the self-reflection and bring that into my office. So I will be asking Carla to release the videos to you and for you guys to conduct If you want, it is not mandatory. If you want, you can review the videos and do a self-reflection. All right, if you have any questions, you know how to get a hold of me. Thank you.